All right, y'all. So this is kind of another sort of a pharmacology sort of general review. Remember, um, functionally, we divide central nervous system into sympathetic and parasympathetic, and this slide really is just kind of trying to show you the happy tension. You can see that um, the parasympathetic primarily is central, and the sympathetic side of the autonomic nervous system is primarily more paraspinal ganglia and peripheral. So this is another schematic to kind of show you the tension between the two. Remember that both sympathetic and parasympathetic side of the autonomic nervous system actually innervate almost all the same structures. They just have buffering actions on each other. So some key terms in understanding the autonomic nervous system are preganglionic and postganglionic, and the names are locational entirely. So a preganglionic event is something that occurs in a neuron or cell body in the central nervous system where the axon is extending to a ganglion in the periphery, and postganglionic is a neuron with a cell body in the periphery that extends to target tissue. So some of the neurotransmitters we're interested in when we look at the autonomic nervous system, sympathetic or parasympathetic, are acetylcholine, norepinephrine, epinephrine, and dopamine. Other terms to remember are cholinergic and adrenergic. So cholinergic refers to acetylcholine. Nerves that release acetylcholine or cholinergic. Receptors that are activated are said to be cholinergic. That includes both nicotinic and muscarinic. And then drugs that affect neurotransmission by acetylcholine are also said to be cholinergic. Adrenergic refers to norepinephrine, and also epinephrine from the adrenal medulla. So remember that norepinephrine is broken down into epinephrine. Nerves that release norepinephrine are adrenergic, and receptors activated by norepinephrine are adrenergic, both on the alpha and beta side. And drugs that affect neurotransmission by norepinephrine are also said to be adrenergic. So the interesting thing about autonomic nervous system regulation is that the parasympathetic and sympathetic systems usually oppose each other, but remember, they don't always oppose. These are some exceptions in salivary, ciliary, and then the male sexual response where they actually work in tandem. There's usually some tone in both systems, but remember, when both sides of the autonomic nervous system are maximally activated, the parasympathetic is the dominant side. So in terms of your adrenergic receptors, you have alpha 1 and 2. And on the beta adrenergic side, you have beta 1, 2, and 3. So if you know these specific locations, you can kind of predict the drug responses. So with alpha 1 receptors, you get stimulation and contraction of all smooth muscle, vascular, and glandular. With beta 2 receptors, you get relaxation of smooth muscle. On the muscarinic and cholinergic side, these contract smooth muscle. And the apparent discrepancy has to do actually with the intracellular signal at alpha 1 receptors. It's actually modulated differently. So some pathomimetics have been with us a long time in the emergency transport field. These are drugs that mimic sympathetic stimulation, and they're usually referred to as adrenergic, although depending on the mechanism of action, that may not always be a good acronym, but it is true. And this is just kind of a list of some that should be pretty familiar to you. So you can either have a mechanism of action that's direct, indirect, or mixed, depending on the individual medication. So a direct action would act directly on the receptor. An indirect would be the release of norepinephrine from nerve terminals, and the norepinephrine would then be responsible for the pharmacologic action. But again, knowing the different subtypes can really help you predict, and it really sort of allows you to know when you're in that therapeutic versus non-therapeutic section, if you will, in terms of managing your patient. So remember also that side effects are not related to receptor actions, and that's what makes them side effects and not predictable, because they are not related to receptor actions. So this is what happens when you get alpha adrenergic effect stimulation. You get constriction of blood vessels. You get mydriasis, contraction of the spleen, uterus. You inhibit the release of insulin, contraction of the sphincter of the bladder, glycogenesis of the liver, ejaculation of the vas deferens, and relaxation of intestinal smooth muscle. And on the beta side, you get positive inotropic and chronotropic effects of B1 receptors. We like to say B1, you have one heart and two lungs. So beta 1 stimulation is almost always going to be hammering on the heart. Beta 2 is going to be hitting the lungs. When you get adrenergic effects of beta 2 receptors, you get relaxation of the bronchioles, uterus, some of the blood vessels. There is a metabolic effect of glycogenolysis and lipolysis and stimulation of insulin. To some degree, a release of renin, and relaxation of the bladder and relaxation of intestinal smooth muscles as well. So kind of the original prototype from the late 50s is epinephrine or adrenaline. And it does have potency that's greater for beta than alpha. So you'll hear people say that its effects are almost entirely beta, which is true. There is some alpha stimulation, a very small percent, but almost none. The interesting thing about epinephrine, though, is with all the alpha blockers that are out there, if you have a patient that is truly alpha blocked, epinephrine doesn't work on them at all. It doesn't work on the bronchioles. It doesn't increase contractility of the heart. It simply doesn't work at all. So it is fascinating that while that may be partially true, it's not entirely true. At least it's a lot more complex than we once thought. So again, the heart-mediated effects, you have positive inotropy, chronotropy, dromotropy, increase in automaticity, and increase in AV conduction rate, excitability, all that kind of stuff. So you increase rate, force, contraction, which also increases MbO2. Therefore, oxygen consumption is increased at an exponential level. And so again, if a patient has a flagging heart, epinephrine may buy you minutes, but consequently, it is very likely to actually push you over the edge in terms of your oxygen demand. The effects on the blood vessel are vast. It has alpha 1 and beta 2 receptors, so consequently, you'll get some squeeze, especially on the venous side, some dilatation on the coronary side, although that is arguable. The skin, mucosa, and kidneys produce vasoconstriction. Cerebral perfusion is actually not changed very much at all. That's one of the reasons epinephrine is actually a pretty good stabilizing drug for sepsis and true spinal shock. Maybe not quite as good for a patient who's having an event that really directly affects cardiac output, a coronary event purely. So then there's Levophed. Levophed has almost no beta effects. Almost all of its effects are alpha, which makes it desirable in certain shock states where you really want to support blood pressure, but you do not want to increase metabolic rate. You do not want to increase heart rate, myocardial oxygen demand. You don't want to do any of that stuff. So it has almost entirely an inotropic effect with very little or no chronotropic effect. So again, you can actually get bradycardia when you give Levophed. If you've given much of it, when the pressure increases, sometimes there'll be a myocardial relaxation and the heart rate will actually slow. It's used to manage hypotension by IV infusion. You can also push dose press it. The side effects are that it does squeeze really hard. It's a heavy cannon. You're really only supposed to use it when the systolic pressure is not manageable above 70 with fluids and other pressors. It does make the blood pressure rise. It can produce anxiety, headache, and bounding heartbeat as well. So then there's dobutamine and dopamine, the drugs that sound alike but are actually not alike. So dopamine is an agonist at D1 receptors. It's also got some D2, D5, D3 effects. It also produces beta-1 effects, which increases cardiac output. And if you dose it high enough, you eventually get some peripheral squeeze as well. Dobutamine, on the other hand, is an agonist at beta-1, which increases cardiac output, but it produces very little, almost no squeeze at all in the periphery. So it can actually give you more cardiac output, but actually drop the blood pressure initially when you first dose dobutamine up. So that's the reason you always have to be careful about dobutamine. We used to use it all the time in congestive heart failure, but you always had to make sure you had a blood pressure to support it. It is effective, but it does lower the blood pressure, at least initially. Dopamine, of course, is our sort of standard pressor of choice. It's kind of the kinder, gentler, nicer pressor. And then there's neosynephrine or phenylephrine, which is another alpha squeezer. Again, it's almost entirely alpha 1. Again, much like levophed, it produces giant vasoconstriction, increases blood pressure. It does produce the same kind of reflex bradycardia. And we didn't talk about levophed earlier, but levophed and neosynephrine, and for that matter, vasopressin, all of your big alpha squeezers that we might give in transport are terribly caustic on the vasculature. So you really need a central line stabilized and secure. You just can't get that stuff infiltrating. It will just cause limbs to rot off. Very bad things will happen. So it's insanely important when you're giving these meds that we're very confident of our IV access or IO access. So beta-2 selective agonists, again, are much more potent at beta-2 than beta-1, hence the reason we're giving them. So they should be more selective for smooth muscle than cardiac. They typically are longer acting because patients use them so much. Usually there are tolerances that have developed. Albuterol was kind of the prototype a million years ago. There are others out there now, but again, the side effects are apparent, usually more by oral route. You see muscular tremors, tachycardia, hypokalemia, and then, of course, the effects of blood glucose do vary depending on when they had their last treatment. But some of the older meds, metoprolol, Alupen, brethine, bronchosol, isotherine, again, all of these are much, much, much older medicines. But as we know, if you take them enough because you can't breathe, your heart rate will increase, definitely. And most patients believe when it comes to beta-2 agonists, if 1 is good, 15 have to be great. So you always have to worry about how many they've had. And then, of course, there are adrenergic blocking agents, alpha and beta blockers. We really don't use alpha adrenergic blockers in the emergency setting. Again, alpha blockers essentially work similar to all the other blockers, and they hit the alpha receptor side and cause no activity. So therefore, there is no squeeze. They block the effects of epinephrine and norepinephrine. Beta adrenergic blockers, however, are commonly used by family medicine guys, cardiovascular guys, and emergency guys as well. So Inderal was kind of the prototype, if you will, is non-selective competitive antagonist of beta-1 and beta-2 receptors. High therapeutic doses produced quinidine-like effects for rate control. It had a high lipid solubility, which is the reason people complain about it making them feel so sleepy when they take it. The antagonism is directly related to sympathetic tone. So the higher the sympathetic tone, the greater the effects of the medicine, both on the heart, decreasing heart rate and cardiac output and pacemaking activity, and on the blood vessels, decreasing peripheral resistance. And probably this is due to sympathetic tone in the central nervous system, but this does directly then cause a decrease in the release of renin, and due to its beta-1 effects, consequently, obviously, blood pressure would fall. Bronchial smooth muscle could also be affected, and there is a metabolic effects in that it would block beta receptor effects of lipolysis and glycogenolysis, again with that quinidine-like effect. So these are kind of showing you over time what beta blockade should look like. Remember that there are interactions of patients who are on beta blockers. Obviously, this increases the effect of a hypotensive agent because the sympathetic side of the autonomic nervous system is how your body compensates for hypotension. It can prolong hypoglycemia in patients that are taking hypoglycemic agents and masks the signs of hypoglycemia, and it can also mask the signs of hyperthyroidism as essentially a high dose of beta blockade would in fact produce the same types of symptoms. So, of course, there's many more beta blockers now. You can almost say there's a lull of the month out there. I swear in these texts, I think we aerially spray sections of the state with beta blockade, but metoprolol is preferred in individuals that have asthma, diabetes, or peripheral vascular disease. It has sort of a time release effect, which makes it much more tolerable for them. Really, the side effects are all the same for all beta blockers. AV block, severe bradycardia, bronchospasm. Remember, there is no pure agonist, so you're going to block some of the beta 1 sites, but you'll also block the beta 2 sites in the lungs. And if they were depending on a beta agonist there to prevent bronchospasm, that would of course make the lungs more spastic. You can exacerbate CHF because you do drop cardiac output. And then all the different metabolic conditions having to do with beta blockade are out there as well. Calcium channel blockers are the IPENE drugs. You know, these are relatively selective smooth muscle calcium channels. Remember, you have both fast and slow smooth muscle calcium influx, but they block or disrupt that both the fast and slow side, resulting in smooth muscle relaxation, decreased cardiac contractility, and cardiac output. They can be used as hypertensive anti-anginal agents and for narrow complex arrhythmia control. In patients where you've ruled out Parkinson-White and the pre-excitation syndromes. Some of the advantages of calcium channel blockers: they are efficacious. They don't have a lot of side effects. They are profound when they do, and they almost always have to do with hypotension. The disadvantages are they almost always have to do with hypotension. So that's the disadvantages, that hypotension with calcium channel blockade is common. You have to anticipate it, be ready for it. And definitely make sure that you do not give a calcium channel blocker to a patient with a pre-excitation syndrome, Wolff Parkinson-White, or Langerhans-Levin syndrome. ACE inhibitors, the Pril drugs, really have come along and really kind of made a big splash in transport medicine. So they block the conversion of angiotensin 1 to 2. Angiotensin 2 is the mediator of the release of aldosterone, which decreases the breakdown of bradykinin, which decreases the sympathetic nervous system, which decreases preload, afterload, and ultimately blood pressure. And the really nice thing about the ACE inhibitors is that you do this and you kind of sneak up on the body's compensatory mechanism, so it doesn't actually realize you're doing this. So there's not a reflex hypertensive episode when your ACE inhibitors are done. So ACE inhibitors can be first lines for hypertension, renal insufficiency, and again, they're definitely preferred in congestive heart failure, particularly in combination with maybe non-invasive pressure ventilation. I almost said IPPV. That's a pressure ventilation that isn't even around anymore, but for CPAP or BiPAP with ACE inhibitors, these are exceptionally effective. And then kind of the next gen are the ARDN drugs, so the losartan and valsartan were the first two. There's a lot more than that now, but essentially these are souped up ACE inhibitors. So instead of inhibiting the conversion of angiotensin, they actually cover the receptor and block it entirely. Again, they definitely cannot be given to pregnant ladies or anyone who might become pregnant. Pregnant ladies aren't even supposed to touch this medicine, so that does very bad things to the fetus. Vasodilators reduce blood pressure by decreasing systemic vascular resistance. And on the veno-arterial dilators, you think of nipride. So nipride is kind of the levofed, if you will, of the dilators. So levofed, of course, is a heavy squeezer. This is a heavy dilator. Nipride dilates arteries and veins, probably mostly veins, some arteries. It essentially disrupts nitric oxide formation, which produces a cascade of events that dilates arterioles and veins and decreases myocardial oxygen demand. It's used in hypertensive emergencies and transport. It's used for really severe congestive failure along with hydralazine, which is the old apresilene, if you remember that, or if you have controlled hypotension post-surgery. The adverse effects are what gets people's attention on nipride. You can get, of course, profound hypotension from this medicine. This medicine always works, and it'll come wrapped in some sort of obstructed silver lining that tries to prevent UV radiation. Once you mix it and put it in the plastic tubing, it's not supposed to have UV radiation hit the medicine in that plastic tubing. Otherwise, there's a solute in the medication that will produce a cyanide thiocyanate toxicity and essentially cause your patient to die of cyanide poisoning, which is really bad, by the way. So again, whenever you give nipride, you're definitely going to be covering it. There are some central adrenergic agonists that can be used, clonidine, methyl-dopa. These reduce sympathetic outflow from brainstem sites. Again, these are definitely not first line, but can be effective in the management of opioid withdrawal, particularly DTs that are producing seizures, which will produce death virtually every time. So, and then of course nitroglycerin. Y'all know that it relaxes smooth muscle, mainly the large veins. Its effects are almost entirely on the preload side, very small on the afterload side. But because you do reduce preload in real time, you do decrease oxygen demand. This is sort of the cascade of events with the administration of nitrates. Definitely indicated in angina, congestive heart failure, when you want to decrease cardiac output, to decrease the work of the heart, or if you're just uncomfortable with how the patient's myocardial oxygen demand appears. Again, nitrates are definitely indicated. Of course, they have hard contraindications, but again, that comes in another lecture. So, and then there's muscarinic blocking agents. These are usually referred to as anticholinergics. Again, these occupy muscarinic receptors and they prevent essentially the actions of acetylcholine on the muscarinic neuromuscular cleft. Essentially, this is what acetylcholine does when you're blocking someone's ability to move. So, all right, so that is essentially Ducey's lecture in a nutshell. Yay.